Ladies and gentlemen, allow me to invite our first presenter. And this is a gentleman known to most of you over many years. Dr. Kalebi is a known scientist in this country. He's a renowned pathologist. We have many years associated him with Lancet. He was a CEO at Lancet, and now the founder, chairman, and the CEO, Dr. Kalebi Labs. I'll ask Dr. Kalebi to step forward and have an opportunity to share with us what he has in store for us. Thank you.
Good morning, everyone. Sorry, not good morning, sorry. Good evening. You can see how life is moving. But actually, I think it's morning. Now, as they're setting up the presentation, maybe I'll just start with a few background information. The lady who came here, Rose, where is she? Rosemary. She's there already busy. So Rose is actually the general manager of RNP. And RNP is, the name stands for Rose and Patrick. It's actually, they have been our IT provider when I started DKL. But I've known them for many years. They have done a lot of work for us, including our Pathology Association, East African Division, that also have been managing our website. So when I started the lab, I had an IT company that we're working with in Pakistan who have designed most of our software. And in the process, as I was setting up the business model for Dr. Kalebi Labs, one of the things we want to do is to have designated service partners. So if you come to our lab, hopefully when you get an opportunity, come and visit us. Some of you guys might have seen it online. It's actually quite a really sophisticated ultra-modern lab. And in the process, what we have done is to concentrate on trying to be excellent internally. And like what I did previously, trying to open up many, many branches everywhere, I realized that's not sustainable. It's better to work in partnerships. So what we are doing now is to work in partnership with existing communities in their localities. Well, like, I'll give you an example. Malindi, for example, we have a designated service partner. The tests that are being done locally, if a sample comes to our facility, the sample is sent to the nearest accredited lab instead of setting up a duplicating platform. But then in the process, whatever is not being done locally then is sent to us in Nairobi. So you can think about it almost like M-Pesa agents or KCB Mtaani. You know, you have agents that you are working with instead of duplicating. So I have colleagues, nurses, doctors, clinicians, lab technologists. Right now we have 22 designated service partners. This is our 22nd. And Rose actually opened the first one in Buruburu. I didn't know about it. Her husband happens to be my IT director, Patrick. You'll see him later. But he's there in his capacity as our IT director. So Patrick, when you are setting up the model, they have the access to the system. Rose said it's something she wanted to try because they have an IT office in Buruburu, and in the process, as I was looking for a designated service partner in the area, She set it up, and that was our first one. It became very, really successful and beautiful. And one day I was lamenting to her and saying, I need to go to Eldoret. I've never had the time to go to Eldoret. She came for a wedding here, met a few colleagues, and I didn't expect this. In fact, I tell them, wow, ni wachokozi sana. Wamekuja wamefungua next to my former place. But that's a story for another day. So the designated service partner, that's how we have this partnership, and we have currently 14 other partners. Some of them have multiple stations. So today was basically to come and launch their DSP, which is basically RNP Healthcare Stat Lab. It will be mainly a service point for coordinating samples from other facilities, and also to attend to some of the walk-in patients who might be referred directly. But in addition to this, they'll also be doing a few stat tests, like you can't end up sending maybe troponin to Nairobi, so we have some point of care for stat tests that are not necessarily locally easily available. And then I found out she had been in touch with Dr. Lotodo, and Dr. Lotodo says, Kalebi is coming, if you guys are coming to do a CME, then let him pick any topic. And I said, let them pick a topic. And clearly you can see, this was the final selection, and you can know why, because of her influence and Dr. Meli. So don't say, why am I talking about this? But I'm going to try and make it very simple. And the purpose of today is to highlight the importance of labs. I have about 35 minutes. I'll rush through a few things, but we can have quite some good discussions at the end. What I really want to look at is how do we look at integrated guideline-based cost-effective approach? Dr. Meli, I have very fond memories of my first times here in Eldoret. She had just come back from Alexandria, and I remember visiting her, and she's like, I can't practice I can't practice hematology. I can't treat my leukemia patients without flow cytometry. And we cracked our heads, and I'm like, no, you have to get flow cytometry done. So we came up with some innovative ways then of getting samples from Eldoret to Nairobi to South Africa when I was in Lancet. And we actually did quite a lot. Today, we actually have several centers that are doing flow in the country, including here in Eldoret. So we make progress. It is by being bold and taking those steps. We have a lot of other technologies, which I'll be talking about shortly. But what I consistently see, and it comes out in a lot in MDTs, one of the reasons why you find patients will leave Kenya, go to places like India, and I'm just going to put it, please don't hold me to it, I'm just talking the facts. Even in nephrology, we see those kind of things. We don't work up our patients completely, comprehensively, and fully. We tend to ignore. We see something might be expensive, and you don't give the patient the option. We think it's not accessible. And that's one of the things we have tried to change, and definitely what I've tried to do in DKL. So the purpose of today's presentation basically is to give you guys a very practical overview and of a clinical-oriented approach to hematological conditions. I'll try to sort of broadly separate them into benign and malignant diseases, but I'll correlate this a lot to other diseases, not necessarily hematological, and the role of modern lab diagnostic in this kind of approach. But more importantly, you as clinicians, particularly hospitals, I visited a few hospitals today, how can you design algorithms, clinical guidelines that can allow people to be treated faster, accurate, in a cost-effective manner? I need to mention this, and I'll come back to it. The word cost-effective is very important. In fact, this morning we were having a discussion with one of the hospitals, I won't mention the name, and you find a patient, recently I had a patient who came all the way to Nairobi for a repeat bone marrow. Eventually we found out this patient actually had primary myelofibrosis. So this patient actually had the many tests being done, no diagnosis. Patient had bone marrow aspirated, it was a dried up, had a trephine, it was said to be non-diagnostic. I'm just recalling back from it. So she happens to be a relative to a doctor in Nairobi. The doctor brought her to Nairobi. So the minute they walked in, in hindsight, I met, she was actually a fairly poorly lady. And I asked her, what's going on? I was sent by so-and-so. I looked at the history, so I told them, you need to do bone marrow trephine and aspirate, you need to do JAK2, you need to do BCR-ABL, we need to do a full blood count, and a number of other things which I told them. The lady immediately said, hana pesa. Immediately. Sisi tumetumwa peke yetu, ile kitu tumetumwa ni bone marrow trephine. So I explained to them that we're going to do the trephine, but based on the clinical differentials and everything, we need everything together. If we do the trephine, she goes away, and we send the results, and we need additional tests, it will not be comprehensive. And I actually told her we might need flow cytometry after that. I took them to my office, explained to them everything. By the time I finished with them, they had already looked for money, and we went ahead and did all the tests. Some of it was paid for by SHA. Some of it they actually got relatives, and we told them, you can pay the balance by the time the results is coming out. And actually it turned out to be polycythemia. Polycythemia rubra vera, actually, which had actually been initially thought to be CML, BCR-ABL was negative, and so on and so forth. My point is, the reason why a patient will come to one doctor, you make one diagnosis, go to another doctor, make another diagnosis, is because you don't have the full picture. And I think that applies to almost everything. So what I will say is take time to actually talk to the patients, explain to them, tell them even if they have to go and come back with the full package, it makes a big difference. Our MC for today actually talked about me. All of you guys know my background. Previously with Lancet. I started Lancet in 2009. I left in 2021. It was actually a planned sabbatical. I planned to actually take a sabbatical to spend time with the family. And then back then, I was never home. So I took 3 years break, but fortunately or unfortunately, I should say fortunately, fortunately or unfortunately, by the time I finished my sabbatical, I'd fallen out with some of my partners from France, we had new partners. Then I decided, why not start my own thing? And it has turned out to be much bigger than I would ever have imagined. So right now, we started DKL, Dr. Kalebi Labs. It's the first private class G lab in the country. We started setting up in May 2024. We launched in October, and by December, we are actually ISO accredited. There are a lot of things I'll mention, and they might look almost as if it's surreal until you visit us. But actually, we're the first lab to have a fully integrated total lab automation. Literally everything. You literally put in, there was a video playing, you literally put in your sample, and it will do everything up to storage, resulting, and everything, and you want to retrieve the results, you want to redo a test, it will retrieve, it's all fully robotic, the first of its kind. Also fully automated multiplex PCR, digital pathology workflow. We don't have a microscope we have a microscope for stool analysis, but we don't have a microscope for histopathology. Everything is completely digital. We use a lot of AI-powered tools, flow cytometry, electrophoresis, NGS, FISH, all this we have set up, and I'll mention some of them. So this picture is actually my last day at Lancet in April 2021. And by that time, we had extended across the whole of West Africa. Now I have DKL. We call it the new era of lab services. This is where we are located. For the doctors who know Pronto, I went to South Pronto. So we're right in front of Pronto, Real Towers, next to the doctors' flats, registrar's flats. Basically 280 meters if you go downwards from Kenyatta. That's where we are. We occupy the ground floor and first floor. Ground floor has our molecular and histology, plus the patient reception. First floor is where our auto lab is, and the rest of it. So as I mentioned, we're actually the first paperless lab in the continent of Africa. And this was actually published by KENAS when we got our accreditation. We got accredited in December, and currently we are on CAP proficiency program, hoping to get CAP accreditation this year. This is our lab reception in Nairobi. You can see where Patrick got, Rose got the inspiration for the design. We got inspired by the Swahili architecture, particularly from Lamu. So this is where our reception is. And as I mentioned, we have the first fully integrated total lab automation. What you are seeing here is the pre-analytical system where you load the samples, it does centrifuging, everything automatically. This is the analytical component, which is integrating chemistry, hematology, this is a hematology line, all fully integrated. You literally put in your sample in the pre-analytical unit, it will even prepare the slides and literally read the slides for you with AI. Sounds like science fiction, it is. You should come and see it. And this is the post-analytical unit. Literally, sample comes here, and if you have ordered for a test on your phone, the test is run. If you want to add another test, it will actually go, retrieve the sample, run the test. If it is normal, result it, take it back. You'll have paid by M-Pesa and will never know that you actually did the test. In other words, it can actually have 100% automation. So that helps a lot because of accuracy, speed, and so on. I spoke about the PCR molecular lab. This is the first of its kind in the sub-Saharan Africa, completely digital pathology with automatic staining. This is our sequencing for DNA paternity. We literally can give you DNA paternity results the same day. You come in the morning with the mama, na mtoto, we tell you go have lunch or coffee, come back in the afternoon, na mtajua mnaenda nyumbani pamoja ama kila mtu anaenda kisha. Literally same day. We say it is 2 to 3 days TAT, but so these are all things that for many years I used to imagine happening in other places, and we're very, very proud to have it. This is next generation sequencing, so everything from BRCA testing to, we've just introduced NGS for myeloid panel. The problem with these ones is you need volumes, so we have to batch. So typically we'll batch 2 to 3 weeks, but we're hoping that we'll get more and more. Because usually you need a batch of about 4 to 8 of each. Flow cytometry, again, this DX Flex, but we also use it with Clear Lab, which is multi-parametric. Now this is really, really important for us, for me particularly. One, when we were starting, I didn't have anybody who had done proper flow training other than the basic that we know. But with this, literally, with multi-parametric testing and this multi-channel flow cytometer, you can actually run a basic panel and it will tell you this lymphoid or myeloid, or not lymphoid, that means it's myeloid. You can run a B-cell panel, and with that, plus integration of AI, we've done some interlab comparison. I'm waiting for the report, but so far it has been really, really, really good, and we have been on some accreditation as well. And literally, you can give you results within hours, 2 hours, 3 hours max. So these things make a lot of difference. CD4, CD8 testing, Helena, which is also the first of its kind in the country, autoimmune and allergy testing, and multiplex PCR. We also have automated urinalysis with microscopy. So these are all some of the technologies that we have, and hopefully when you get time, you will come and visit us, or we can discuss about it more. We do have a nationwide sample logistics, so wherever you are, before we, Patrick, before Rose opened here, anybody could send samples through Wells Fargo. So if you have a relative of yours in Kitale or in Hispania, they collect a sample, we have a free delivery, and as I said, you can order for tests online, look at your results online. So even as you are here, you can download our app, register, and as a doctor, you can have an account where you can view results from your patients and track them. Another thing I just wanted to mention quickly is all our prices are online. So hatufichi bei yetu. Our turnaround time is also online. You literally can go in on www.dkl.co.ke lab test, or if you go to our website, look at other lab tests, and you can search for any price. It will tell you, for example, genetic sequencing. And we try to pride ourselves that this is, we are very cost effective in most of the tests, except histology, which we are a bit more expensive. And that's story for another day. So our app allows patients to navigate, doctors, and so on. You can even order for tests online, and we have a 24-hour call center. So quick mention of, when I talk about innovation, it's not really anything. New processes or new techniques in an existing paradigm, So you have the vision, you have the creativity, you look at growth and development. Usually most of these things will be inspired by certain things that have affected us. And a lot of the things you'll see us doing now is not really because of being some fancy, clever person. These are actually basic things that have been really bothering us. They really, really bother us. You look for, like right now, I'll give you an example, Cystatin C, when I was talking about Kenya Renal Association. We get a lot of frustration with creatinine, its limitation. So we start doing Cystatin C. So it's not really that you are really innovative. Innovation just basically means you have a new idea or a new process or a new technique, but now to try and create value. And one of my ethos here is to look at competition. You know, you compete, you collaborate and compete. You know, I was telling Rose, Lancet is next door. They might require a quick test when their machine is not working, and vice versa. We work very closely with MTRH and so on and so forth. You cooperate and you compete. Somebody actually gave me that example this morning. One of the CEOs in the hospital said, you have to be friendly to other hospitals because you might have a 4-bed ICU. They have a 4-bed ICU. If you're not friendly, the day your ICU is full, and it might just happen to be a relative who needs the 5th bed, which you don't have. If you don't support the other hospital, will they be there for you as a backup? So patients will always be there, and the world is, there's too much fish in the ocean. We can all fish and really do well. So the issue of strategic alliances becomes key, and that's why we need to look at innovation and partnership. And today's basically discussion is basically to look at how can we look at underutilized capacity, the issues of duplication, avoiding wastage, you know, demand creation. This is basically what we are discussing here. And that is all anchored on the WHO pillars of availability, accessibility, affordability, acceptability, and quality. I can tell you, a lot of the time, the issue is not availability or accessibility. Most of the time, it's affordability and acceptability. Yeah? We have this sense in our mind that something is not available, something is not acceptable to the patient because of cost. We don't give them the option, and I'll be talking about that. And finally, before I go into the actual substance, very, very fast, is the issues of how can we partner, you know? So one of the things is lobbying and promoting tests. When I promote tests, people tend to look at me as promoting for business, but I tell people we are like evangelists. You know, evangelists, they pray for people to go to heaven, but they take teeth. It's called teeth or teeth. Eh? Tithe. They take tithe. Eh? And they also go to heaven. They make money, they save people, and they save themselves. So when I preach tests, forget about that I'm here to try and make money. Think about I'm trying to save you and your patient. The money is secondary, but don't faidika. But don't think about it as the primary. The primary is what do we do for the patients? Yeah? We should be bold about it. Okay? Issues of referral network, service collaboration, outsourcing partnerships, and so on. So to come to the core of today, precision laboratory diagnostic hematology, and this will be quite basically a very fast-moving matatu. Some of you guys must have seen this. I've used it for many, many years. Anytime you do a test, it always begins with a clinical question. And I've asked people this often. Let me use a different example from hematology before I go to hematology, because I want to talk about UEC, since we have a nephrologist in the house. I want to embarrass you guys a bit. How many of you, you don't need to lift your hand for this one, how many of you order urea electrolytes and creatinine routinely? I know almost all of you. So a patient comes, you do UEC. And you do other tests, but I just want to specifically look at UEC. Now, if you ask somebody, why did you do the UEC? Since when, and I can talk for myself, since when did you actually interpret a chloride result and it changed the management of your patient? Nyinyi hapa, watch a nephrologist. Less than 0.1%. Calculate. So why are you doing it in the first place? Since, how many times do you get your sodium being useful in your interpretation? Now, potassium might be relevant in some cases, but why are you doing the urea in the first place? So, I come to your clinic, Mimi Kalebi, Then you say, we need to check your kidney, we need to check this, we need to check that. Then what do? You do for me a UEC. Just because I'm wearing a suit and I have money or have an insurance. The point is, what are you trying to answer with that test, UEC? So people will say, I'm trying to check the kidney. Doc will tell you, in that case, Dr. Cheptinga will tell you, in that case, the most important test is what? I'm not going to embarrass you. It's actually urinalysis. Urinalysis with microscopy. How many people do urinalysis with microscopy? Mnafanya ile dipstick, hata angali vizuri, they don't let it dry enough. Then, mtu anaona iko 1+ protein, inakuja kwako, I can see physicians in the house, unaona hiyo 1+ protein, you ignore it. A few months later, things are... My point is, we do tests without asking why are we doing it. The most important test, and I can say this authoritatively, is urinalysis for if you're looking at somebody's kidney function, if you're looking at somebody's kidney status. Then after that, do a creatinine. If the creatinine is normal, why do you need to do a urea? So why did you do UEC? You should have done a creatinine, use the money for the U and the E's to do another test. Are you getting my point? I'll finish off. I know I spoke about it in Eldoret 2 years ago during Kenya Association of Physicians. So I'm going to flip it from a test that people overuse to a test that people underuse. Pro-BNP. How many of you have done a pro-BNP test on your patient in the last 1 month? Okay, no, 1 month is a lot. 1 week. Very few. And probably the ones who did the pro-BNP did on a patient who had heart failure. Now, if a patient has heart failure, why are you doing the pro-BNP? Because the patient already has heart failure clinically. You are going to do echo. So how are you doing? The most important role of pro-BNP is to screen and determine early stage heart failure and then monitor. Now, the guidelines say every patient who is hypertensive must do a pro-BNP. How many of your patients have you done pro-BNP who are hypertensive? None. So that way you can look and identify stage 1, stage 2 heart failure before it goes to stage 3, which you can now pick on echo. Any patient who is diabetic should do pro-BNP at least once a year. Any patient who is obese should do a pro-BNP once a year. etc., etc. I gave this talk at Kenya Association of Physicians, and Professor Ogola said, that was 2 years ago. 3 years ago, actually. I was on sabbatical then. And Professor Ogola said, but pro-BNP is expensive. That's why we don't even do it. We'd rather even do echo. And I challenged him, I said, we need to have more numbers so that more people do it. The cost will come down. And I remember he said, which was very profound, he said, but if the price is better, more people will do it. So it's a chicken and egg situation, which comes first. But how many of you know that SHA pays for pro-BNP? Yes, thank you. Clap for Dr. The only informed person in this whole, SHA actually pays for pro-BNP for general patients. Anybody who is a SHA member can get a pro-BNP done. People charge 8,000 shillings, 6,000 shillings for pro-BNP. What's our price for pro-BNP? I think it was 3,000 shillings. Now, literally, if you think about it and go back to your hospital or your clinic, literally every patient who walks in there once a year will end up having a pro-BNP because most of your patients will form into one of those comorbidities. So we are busy doing UEC and they're not doing pro-BNP. For the patient who needs pro-BNP, so do the creatinine, do urinalysis, then do so the reason why I'm going into all that, and it will tie into my discussion, when you are doing a test, you should always ask yourself, what's the clinical questions you are trying to answer? Because that is what will determine your test selection, what you'll order, all the way up to the result interpretation. So a good example is FBC. We do full blood count. When you do full blood count, what are you trying to answer? What is the question? If you don't, I know when I was an MO, I was working in Mombasa Hospital as locuming. I used to send patients for FBC. I'm confessing. I used to send them for FBC so that I can read. By the time they come back, I've quickly read. I know what I'm going to prescribe. because they have to walk to the lab, come back. You get? But the point is, how many of you actually look at the results and try to interpret them? So the objective of the next few slides I'll be talking about for the next 10, 15 minutes is basically to understand the broad classification of hematological conditions, basically put them into benign and malignant. And these conditions will affect all of us in terms of our patients. There is no specialty in medicine that will not encounter hematology. So I'm going to give a very broad talk, not catered to the specialist hematologists and the rest. Why? Because, and I've mentioned this a lot to other specialties, we need to actually teach the general practitioners, other specialists, because those are the people who will identify a patient, investigate them, and refer them in time. Otherwise, if you want to say you refer people, by the time they go to the specialist, get access. There's a patient whom we actually referred somewhere, and to KUTTRH. Not a relative, but somebody who was referred by a colleague. So she went and she was told, come back after 3 months. And this is a patient with MPN. So, but by the time she was going there, she already had. So I quickly called Dr. Oiro and I said, Dr. Oiro, I have this and this patient. She said, I'm later. This one, we just start treatment immediately and then you can refer her back to Nakuru. You get the point? So a lot of the time when you have the right diagnosis, so these things are not difficult things that you need to know. They just need to be aware of. Yeah? How do you develop a systemic approach to interpreting abnormalities on the full blood count, review major categories, contribute diagnostic tools, and so on and so forth. So broadly speaking, I can tell you, you can broadly think about hematology in 2 ways. Benign and malignant, but it's not so easy. Because in hematology, you remember we used to talk about benign in terms of metastasis. But there are conditions in hematology that are malignant and it's not about metastasis. Think about it, and this is simplistic. Think about hematology in terms of what is clonal and what is non-clonal. Clonal means the same population of cells of the same phenotype has multiplied, which means it is one line, which means it is neoplastic, which means, depending on the behavior, it is malignant, it is neoplastic. There are conditions that can mimic what is malignant, but they can even kill, but they're actually benign. And there are conditions that are malignant, but we don't even bother with them. So key thing is to identify what is clonal, what is non-clonal. So benign conditions generally are reactive, what we call reactive. And they can occur because of many things, infections, deficiency, and the rest. But malignant conditions, and this is key. If you understand this, it will make your life very easy. Malignant conditions are those ones which are clonal. They arise out of a genetic mutation, an abnormality, which leads to one population of cells that multiply. So all the things we're going to talk about, next generation sequencing, FISH, molecular testing, because we are trying to identify the abnormality associated with that. And that's why the world has moved. I can tell you, unfortunately, that the current WHO classification, you can't make a diagnosis of leukemia, my colleagues are here, without molecular testing. True, Dr. So, if you don't do molecular tests, it means you didn't make a diagnosis. A good example, you know about chronic myeloid leukemia. If you don't make a diagnosis of, if you can't do BCR-ABL and you confirm, hiyo ingine ni mitishamba. I'm sorry to tell you guys. See mimi, abu open guidelines, mko na Google hapo, mufungue. That is the truth. Imagine, many years ago, we will say, somebody has this, Professor so-and-so says it's this, now this chronic myeloid leukemia. They have splenomegaly, but right now, I just had a patient last week who was diagnosed as CML. We actually had a discussion in the MDT, but it was completely BCR-ABL negative. We did qualitative, we did quantitative in our lab, it was all negative, and eventually the patient actually had something else completely different. So molecular testing is right at the end. But think about it, it is what you need to make a diagnosis. So if you are sitting in some clinic somewhere or a hospital somewhere here in Eldoret today, and your patient actually has leukocytosis with neutrophilia and all the features that you think about, this is looking like chronic myeloid leukemia, remember that it is driven by a mutation. And the world has advanced so much, we can actually test that mutation. If you are talking about somebody having polycythemia rubra vera, we can actually test JAK2. And you can look at exon 12, exon 14, and determine it. This is where the world has gone now. But I'm sure if I ask you guys, you'll say, it is expensive. Okay? So think about the patient came and saw Dr. Meli. No, you are referring a patient to Dr. Meli. The patient actually had a WBC count of 347, has splenomegaly. Aende a queue. By the time anafika hapo kwa Dr. Meli ameenda sijui kwa CEO, anaambiwa akuja the next clinic. Yeah? That patient, by the time they actually get to see Dr. Meli, then Dr. Meli asks for a BCR ABL, anamwazisha hydroxyurea or whatever. By the time they come back, if you think about it, and this is the point I really want to emphasize to everybody here, the cost of delayed diagnosis, the cost of delayed care is actually more expensive than the cost of diagnosis. Trust me. BCR ABL, I think we charge for qualitative around 9,000, 10,000, which might look like a lot of money. But I've seen patients who come with 10 FBC results. You've seen those kind of patients. So you're wondering, this patient already had leukocytosis. Why are you doing 10 FBC results? Each FBC, some hospitals charge 1,500, 1,600 in Nairobi, other places. But even if it is 1,000, you might as well have done the BCR ABL in the first place. Do you get my point? So, understanding the pathology of what causes that is basically what allows us to make the diagnosis. And it is very critical because some things are urgent. I mean, we get patients with even a white cell count of 400, 500 T-cell leukemia. You know, I mean, T-cell acute lymphoblastic leukemia. And these are patients actually literally who are going to get into a crisis, stasis, and so on. So what I'm trying to say is you can have a clinical diagnosis, you can suspect things morphologically, but where we are today, precision lab diagnostics, you must do immunophenotyping, you must do genetics. There is no other way. So correct early classification basically actually improves a patient's outcome. So when I talked about the benign versus clonal, the benign are mainly things like infections, inflammation, physiological stress responses. The rule of the thumb, I'll tell you, if you suspect something is benign or reactive and it persists, think again. It's as simple as that. You have a patient who has high white cell count or low white cell count. A patient who has polycythemia or they have anemia. Always ask yourself, what else could it be after you have excluded things that you expect to have resolved very, very fast? And when we talk about the clonal things, we talk about acute leukemias versus chronic leukemias, but they all behave very, very differently. Even within the same group of acute leukemias. Because of time, I'll just run through it. So the benign conditions, and basically in hematology, the FBC. I mean, I'm a big fan of FBC. I think we should do it more often. But always ask yourself, what are you looking for? You don't just do it, and you don't even look at it. You just look at the HB. HB of, I've seen people say a HB of 9. You're simbaya sana. Yeah, because you are told patients in Kenya can have a HB of 10 and they are still, but you ask yourself, why you, especially like men, why will a man have a HB of 11 or 12? Ask yourself, what do you do next? Key thing, you can broadly, when you look at an FBC, for purposes of today, you ask yourself two things. Is it high or is it low? High means there is cytosis. So it could be thrombocytosis, increased platelets. It could be leukocytosis, increased white cell count. Or it could be erythrocytosis, polycythemia. Or cytopenia. And believe you me, leukemias, these clonal conditions can present with either cytopenias or cytosis. You don't necessarily need to have increased white cell count to say this is a leukemia. Okay? So the FBC is a screening test. And the minute you look at it and something is abnormal, please don't send that patient away without asking yourself what it could be and making a follow-up. Very, very important. And the reason I'm making this so simple, because it applies to all of us. I have seen, sorry, Dr. I've seen nephrologists missing leukemias. I've seen surgeons missing leukemias, myelodysplasias, because they were focusing on one thing. Even gynecologists, somebody came for hysterectomy, they were quick to to transfuse so that they can do the hysterectomy. Na ametuma mgonjwa. You get? All of us, you are a lab technologist in your hospital, a patient comes, has leukocytosis. It's upon you to actually tell the patient, these results look abnormal, who is your doctor? Please bring it to the attention of your doctor. Because sometimes people then overlook these things. So further testing becomes essential. So for the cytopenias, basically you're talking about reduction in blood cells, but the key thing here is, with anemia, what could be causing the anemia? Thrombocythemia, what is called pancytopenia, what is causing it? So typically, the broad causes are, with cytopenia, it could be decreased production. Something is causing a problem in the marrow, and there are many, many causes. And that's why we have Lotodos and Melis of this world. Because you look and you say, I can't explain this, let them go and be reviewed. As I told you, leukemias can present with cytopenia as well before they have cytosis. It could be increased peripheral distraction. So you think this person has increased peripheral distraction, what can you do? We have all those tools. If it is hemolysis, you can do haptoglobulin. Remember, you don't have necessarily to get increased bilirubin, because the liver has a big threshold before you actually present with jaundice. So in this case, you can actually do other tests. Easiest thing, I'll try and make this very simple. Every time you see a patient, ask yourself, what could be causing this? And when you think about it, nowadays we have so many tools. AI, ChatGPT, Grok. You have books, you can Google. And you say, hey, it could be this. Ask yourself, am I seeing that? If you're not seeing, send to a specialist. It's as simple as that. So cytosis, on the other hand, I don't need to go into this, but it's increased cells. Every time you have an increased cells, could it be reactive? Could it be clonal? At your level, if you're not a specialist, the assumption should be, unless I have an explanation to explain it, then it is malignant until proven otherwise. So if a patient came and they have fever, all that, and when you check them, you found they actually had some infection, which you can clearly confirm, that's different. If a patient has polycythemia, they're a smoker, and you know they have COPD, that's different. But if a guy comes and he's completely normal otherwise, then you have to worry about polycythemia. And it's one of the most commonly missed diagnoses, for that matter. So what do? There's no need of doing erythropoiesis. Not erythropoiesis, erythropoietin. Those are the things we used to do then when you didn't know the diagnosis. Now we know what is the cause. You can go straight and test for the cause. And many other things, I can give that example. So, literally, the reactive versus clonal, reactive versus malignant, the key thing becomes clinical correlation will guide your testing. So, in terms of the malignancies, a few more slides. In terms of the malignancies, these are broad classification, either myeloid or lymphoid. I wanted to put some slides and I thought, what's the point? Not all of us look at slides. But myeloid versus lymphoid, Kitambo used to guess. Even now we still guess. Yeah? I can tell you, I have very good pathologists in my lab, Dr. Angela and others. There are times when they say, they can literally swear by the Bible. Dr. Meli is smiling. This is ALL, this is acute lymphoblastic. Then the flow comes and it is AML. And you go like, no, something is wrong. You go back to the flow, it's clearly AML. How are you able to make that diagnosis? Because flow cytometry, and we can do immunohistochemistry on bone marrow as well, allows us to be able to determine the phenotype, the immunophenotype, using immunoglobulins. Again, it's specific, so we can be very, very sure. And that's why we do these things, because the treatment of one is very different from the other. So the key thing then becomes, myeloid or lymphoid. And believe you me, anybody who says otherwise is guessing. We've seen cases that people are so convinced that this is myeloid. It turns out to be lymphoid. So you really want to be able to confirm these kind of things. People will tell you about costs. I don't know how much is flow at MTRH. Huh? 13. 30,000 for acute. For chronic. So 30,000 for acute, which is not a bad package. Now, think about it, 30,000. For us, we charge sort of like stepwise, depending on what the pathologist has already seen or the morphology. So you do a basic screening for 14,000, which tells us lymphoid or non-lymphoid, with 10 markers. Then if you think it's ALL, there's a panel, but broadly speaking, it will be where we have morphological diagnosis, we can do a basic screen at 15,000 and 33,000 for the full panel, regardless of the number of markers we'll do. But 30,000, I have seen a patient who was brought to us in an MDT in Kenyatta. Patient had been in the ward for 4 weeks. I don't think it was because of negligence. I think it's just because of the way we operate. You know, people come and do ward round. Understand, Nini? To be continued. What do they say? CT management. So this poor patient, nobody is actually really following up. But the patient really became sick. When it came to us, we did it. But I thought about it. Kenyatta, if you calculated how much money they were paying per day for the bed charges, you know, and if you calculated how much the relatives were spending to come and visit, you know, nowadays Kenyatta they allow a maximum of 2 patients per day. How many people are coming to visit every day? All that money in the last 1 month, if they're done flow from the beginning. Now, you guys know about PML-RARA test, yeah? So a PML-RARA test is one of the genetic tests for acute promyelocytic leukemia. You can't make a diagnosis of acute promyelocytic leukemia without PML-RARA. Otherwise, it's a guesswork. It only costs about, I don't know, we charge, I can't remember. Brian, you know? You can check quickly. PML-RARA, I think it's like 13,000 or 14,000. But literally, it makes a life or death decision because somebody started ATRA, and do they stop, do they continue? 16,690, that's our standard price. The leakage is that all public hospitals get a discount. So I know Kenyatta, we charge them 13,000. And you literally get your results within 4 hours. But it makes all the difference in terms of management. And I've seen patients die because of not being tested accordingly. You guys have seen the same thing. So today's message basically is we have the diagnostic tools which integrate morphology, immunophenotyping, genetics for literally everything. And we can be able to make a diagnosis and make a... So for you, doesn't matter which level you are. Some of these things are critical emergencies. You can't wait to start saying, I mean, for me it's criminal when you see, I'm talking about very recently, we had a young man who died of APML. And the patient was actually seen by a competent physician. I think he was 18 years old, young male. Competent physician. Then writes a referral to go and see a hematologist. By the time they get to the hematologist, this was on a Friday, by the time they get to the hematologist on Monday, literally too late. The kid actually died that night. DIC, everything. So you really need to be able to, these things are unforgiving. Some of them are forgiving, some of them are unforgiving. The key thing is, when you see these kind of things, think about it, ask about it, test as soon as you can. And nowadays, literally with ChatGPT, will even tell you, do this test. You can do the test as you are referring. By the time they're getting to Dr. Meli knows exactly what to do. Not to start now, ndo anaanza sasa kufanya vitu zingine, it's going to take time, wherever the patient is. So, an integrated approach becomes essential. There are those conditions you can do stepwise, but there are those conditions that you do everything. And you tell the patient, this is what we have for you. So, to summarize the different diagnostic tools, basically, we in our lab, we use an automated full blood count analyzer, As I said, it does even the morphology, and then the pathology just reviews. Bone marrow examination, flow cytometry. I spoke to somebody today about bone marrow examination. When I was training in South Africa many years ago, that was in 2006, I mean, interns do bone marrow trephine as a bedside procedure the same way they collect blood. Because there, we used to have a professor called Professor Patel. I don't know if he's still active. But Professor Patel will say, if you can't make a diagnosis clinically and you're not sure, you must do at bone marrow. And there's no contraindication to doing a bone marrow. Even if somebody has a platelet of 2. In fact, somebody has a platelet of 2, that is the one who needs the bone marrow. Do you get the point? Because if you have a platelet of 2, and we think the problem is in your bone marrow, if we don't do the bone marrow, then how are you going to make the diagnosis? So it is literally a bedside procedure. So I spoke to somebody this morning and I said, we are very happy to even organize for training. Because for us, bone marrow should not be done by pathologists or hematologists. Bone marrow should be done by everybody. The only ones the pathologists will do are those difficult ones of myelofibrosis, where somebody got a dried up things, or some myeloma where it was breaking, so you refer for further. It's as bad as saying that every other appendix, every other acute abdomen must be done by a specialist GI surgeon. We'll lose a lot of patients. Some things have to be trained to be done even at the most basic level by MOs. Now, flow cytometry is something I really needed to mention. Flow cytometry is a basic tool. It is not a specialized test. And SHA pays for it, by the way. The only problem, they're still paying kidogo. So we are trying to talk to Dr. Meli, the CEO of NCI, to make these guys understand. Because the regulation is very clear. They pay per marker, but they're only currently paying for a few markers. They should be able to pay for panels. But these things are there. They pay at least 8,000, sometimes up to 16,000. And if you refer to us, we actually get authorization, then the patient just tops up. Believe you me, I've had cases, patients coming from Kenyatta. I mean, most of the time it's a mother who's bringing a sample, or a husband for the wife. And you go, they actually don't have money in their pocket. And they have that sample. It's a bone marrow. Listen to me carefully. That marrow has to be run. That sample has to be run at that time. Why? They can't go with it home and come back after 2 days. You know, this is not like a sample in formalin. So most of the time we'll just tell them, just sign here, we'll run for you the test. They'll go look for the money and they'll pay. But that makes all the difference. That determines, and there are drugs that Dr. Meli gives, and literally, it's chalk and cheese. Today, patient comes, is very sick, you come after 48 hours, you even wonder, is this the patient? If you get the blood count, you even see. It's like a miracle. We are miracle workers, but you cannot do miracle if you know what even those, called Professor Oro, he's in Brazil, eh? I saw something, he's in Brazil. You know, you have to know what you are praying for. You know, I keep telling some of my staff, you need to know the problem you have so that you can pray. If you don't know you are sick, how will you pray for health or for cure? Because you won't know, you'll be praying for other things. Anyway, because of time. So when I spoke about automated flow cytometry, automated PBF, basically this is what we have. If you get time, you can come and see it in our lab. You literally put in the sample, and it prepares the slides. It's not very, very clear. And it actually can interpret it for you, and it will tell you everything, okay? From the morphology. Morphology remains key, and the pathologist always takes precedence. I spoke about bone marrow. Immunophenotyping, I spoke about it. Now, to finish off, molecular genetics. Now, I just want to make it very, very simple because of time. Molecular tests basically look at the molecular level. But there are 3 main tests, okay? There is PCR, is polymerase chain reaction, the same test that we use for HIV viral load and so on. Most of the time, these ones, we are looking for mutations, point mutations, single gene mutations. So things like JAK2, that's a single gene mutation. It can be one type of gene or another. We're looking at something like BCR-ABL, PML-RARA, all these are single gene mutations. So these are single gene mutations that are associated with specific conditions, like chronic myeloid leukemia. You don't have to remember them, but know they exist. So that when you have a patient with chronic myeloid leukemia, you can literally go to ChatGPT and ask, what is the most appropriate test? And it will tell you. Now, you can do FISH as well. So FISH is fluorescence in situ hybridization. We started doing it in our lab. We just finished some of the validation. It's the same one that we also use it for HER2, FISH, and the rest. Now, this one is actually using probes, and it will look at a group of genes because it's chromosomal, so you're looking at a bigger region. Okay? So the FISH is also used for cytogenetic testing for a lot of the leukemias. But the superpower in the house is NGS, next generation sequencing. So what next generation sequencing does is basically we are able to look at multiple genes at once. So for example, you can literally do NGS for myeloid leukemia, and it will give you all the genes that are associated with it and tell you what's positive, what's negative. And it just comes as a panel. It tends to be much more pricey in terms of cost, but in some circumstances, you cannot avoid them. FISH tends to be a bit cheaper if you're looking for specific markers, but NGS becomes the most preferred. So my hope, I mean, I can't believe this. It almost looks like I'm dreaming, because I had a talk similar to this with Dr. Meli 14 years ago, 12 years ago, when flow and immunohistochemistry sounded like a dream. Yeah? I think in the next 3 years, not even 10 years, doing NGS will be kawaida. It's all about economies of scale. But the most important thing about all this is not because we are trying to do this for diagnosis and to look good as pathologists or the physicians. They actually determine treatment. It is amazing. I'm telling you, the kind of stuff, most of those drugs, I don't even know them, and I'm not even going to bother knowing about them. I just hear this and this and that and that. I don't even think these guys know them. Most of the time, they read before they come for the meeting, and then they sound very clever. But they can't remember most of those drugs, our oncologists. So don't think they are so clever. I know the other week, actually yesterday we had an MDT, and we had a patient with desmoid fibromatosis. And when I was presenting, and I mentioned something, one of the oncologists, it was a Kisi, so Dr. Kemunto, she quickly checked, because I confirmed with her later, she quickly checked, and now she was just saying these drugs. I was like, no, she said, the minute you told us the diagnosis, I quickly checked, so I was able to give you guys the drugs. Because these drugs are so many, kweli wango daktari. So don't think that those days of memorizing everything is gone. Nowadays you can look up anything. But my point is, the drugs are there that are so specific that they can target a specific genetic change and literally cure the patient. That's where we are. Believe you me, Professor Binya said one time, and I agree with him, some of the leukemias, some of the malignancies are more treatable than pneumonia. Let that sink in. The mortality rate of pneumonia, what is pneumonia? Niko nasema ni pneumonia, hiyo si pneumonia. Mimi nasema pneumonia ukweli, pneumonia of the lung. Ile pneumonia, the mortality rate of pneumonia is higher than the mortality rate of quite a number of cancers. Cancer now is actually treatable, believe you me. So this guides targeted therapy, and when you talk about precision medicine, this is what we are talking about. So just to summarize, all these things have guidelines. And these guidelines, some of them are consensus guidelines, some of them are based on evidence, but every time you have a patient, and I'll make it very simple. For example, you get a patient with, actually let me use this as a practical example because I was discussing yesterday with Dr. Angela, and we have had patients like this. A patient comes to you with anemia. It's microcytic hypochromic anemia. Why is it microcytic hypochromic anemia? Because the FBC says there's microcytosis, you can see that, there's hypochromia, so it's microcytic hypochromic anemia. How many of you go ahead and just give hematinics? All of you. Guilty as charged. The one who doesn't give hematinics without further investigation, ebu simama hapa nikupatie zawadi. And prove it. All of you. I don't know, you are excluded because you are the one who teaches us. So, mimi nasema watu wengine. Not Dr. Meli. Why? I can tell you the causes of microcytosis and hypochromia are so many. I have seen patients going into iron overload, being treated for iron deficiency anemia, when the lady does not have iron deficiency anemia. My wife was almost a victim because she has alpha thalassemia. So, easy thing, do an iron profile. How much is an iron profile? Brian, how much is an iron profile roughly? Standard price? $6,600, and that one you are including everything up to UIBC and TIBC. If you just to do iron and ferritin, it's just basically about 2,000, 3,000. Yeah? But when you do that, by the time you're actually giving that person the hematinic, you are giving for sure. You get my point? Another example, how many people just give B12 for and folate for macrocytosis? In fact, that's even worse. Because the causes of macrocytic anemia are so, or macrocytosis for that matter, are so many. So what I'm trying to tell you guys is, don't say Kalebi alisema, no. When you get a patient with anemia, you know, if the patient tells you, the lady tells you, I have fibroids, I have been getting menorrhagia, you know, clinically, you make a diagnosis, you'll give hematinics. But the man has no reason to have iron deficiency. The woman has no reason to have iron deficiency. And you are saying this iron deficiency anemia, go to the next level. Investigate. Not because I want you guys to send us, you can even use other labs, but please do the right thing. And the right thing is, there are algorithms. Those algorithms guide you, and you go all the way. We've had very interesting cases of things that people miss, never been made diagnosis here in the country before, but simply because the physician thought and went, what next, what next, what next? So I was going to talk about this, about the different approaches, but I've already mentioned it, so I'll just quickly say from a guideline perspective, if you have cytopenia, you need to confirm the abnormal results by repeating where necessary, particularly if you're doing in a lab where you are doubting the results because of accreditation. You need to do, iron studies are basic. Let me repeat. Iron studies, appropriate vitamin levels are basic. They're not advanced tests. If you're looking at them at basic, you are actually doing disservice to your patient. Bone marrow is not a specialist procedure. 20 years ago, I was in Baraguanath. Bone marrow was being done by interns. I don't see why MTRH interns should not be doing bone marrows. Because these are basic tests. So in our lab, actually, I stopped my pathologists doing the bone marrow. We get MOs, we have trained them, and they are there. You can walk in any time and do a bone marrow. You don't need to be booked. What? Then now you can manage it appropriately. If somebody has cytosis, as I said, if you have a clinical diagnosis, a Kishua, of an inflammatory condition or an infective condition, treat. Patient is not still responding. There is persistence. You have to go back. Then now you look for clonal markers. Clonal markers is basically immunophenotyping. After that, molecular testing. Then now you send for specialist evaluation. Are we together? If you are suspecting malignancy, do the basic, do whatever the patient can afford, then send to the, because by the time somebody is going to Dr. Meli, if clearly the person had, you are suspecting CML, Daktari, have you given like, I was going to say fatwa. I'm a Muslim, so fatwa is like a decree. Have you given a decree that only you can prescribe BCR-ABL? All of you guys, you get a patient and you suspect that this is CML, do BCR-ABL. If it's positive, you are referring to the hematologist, oncologist directly with the diagnosis. Those are the some of the things you need. So just take home message. The key thing is to distinguish between reactive and hematological, clonal. And if you cannot be able to confidently say this is reactive, And you can say clinically this is reactive, but if it doesn't behave like reactive after some time, and it's still persisting, and I've seen patients like that, patients can have mixed things. They can have an infection, and they can still have clonal problems. But generally, they should respond to your antibiotics. They should respond to whatever you are giving them. Yeah? So, some people say, oh, this patient has thrombocytosis, it's reactive. But why somebody have reactive thrombocytosis for 3 months? Then you find later this person actually has myeloproliferative neoplasm. And then all these things lead to integrated diagnosis. So thank you very much. I hope I've opened your eyes, and I'll be very happy to contribute to the Q&A and the panel discussion. Thank you.
Ladies and gentlemen, I think you have got every reason to repeat your claps. Kindly clap for this gentleman. I have listened to Dr. Kalebi over years. And every time it only happens that we meet in such kind of meetings, because I don't have many other reasons why we should be meeting frequently. But because of that simple reason, I always learn something very important. So imagine a young clinician with a simple idea, an idea that could save lives, but nowhere to test it, build it, or scale it. Too often, that idea will fade. So today, in this meeting, I have learned a lot. First of all, I know you guys, the most important slides were clinical slides, but the first few slides were very important. And the slides which were important are, do you guys remember seeing a slide on innovation? Yes. Innovation is in DKL. It is something that I quietly followed, and if you saw something going around, that's a patient journey map. And that's what we use in, human-centered designs to find in places all in that journey map where you need to intervene. And I'm very grateful and very proud of Dr. Kalebi for taking this opportunity to take us through a patient journey map and identifying various points of innovations, and some of them treating them with collaborations, others, partnerships. And if you listened carefully, he's been around this whole day, walking around the hospitals in Eldoret, trying to understand what goes through in these hospitals. And I do believe it's the reason why a number of you are seated here this evening. So, good evening. My name is Dr. Morgan Richard. I'm an obstetrician gynecologist. I work with Moi Teaching and Referral Hospital. I'm a member of Fortune 500 investment group, and I'm the Kenya Medical Association Vice Chairman. And within KMA, I convene the awards committee. With me, there could be some of our council members. I'll quickly ask them to stand up. I can see Dr. Daisy. Hey, this is not a forum to introduce our newly elected Vice President KMA. I think you should clap for him. Yes. So Daisy Wave and our Vice President will have a forum to receive you formally. Mbuzi, I know Professor Kimaio is very benevolent kwa kupeana mbuzi, tuchinje tukule. Thank you very much. Karibuni nyote. So, to do justice to the presentation that Dr. Kalebi has done, I want to invite a few of us in front here so that they can answer a few questions you have. The first discussant will be Dr. Enoch Serem. Dr. Enoch Serem is a clinical pathologist at Moi Teaching and Referral Hospital. He has a lot of interest in hematology, microbiology, and immunotherapies. Ladies and gentlemen, put your hands together for Dr. Serem. Dr. Serem will be assisted by Dr. Beatrice Melly, who has been widely mentioned by the speaker this evening. Dr. Beatrice Melly is a clinical hematologist. She works at Moi Teaching and Referral Hospital. She has a 10-year experience in managing benign and hematological malignancies. And she's been privileged to have an opportunity to be a principal investigator, especially in multiple myeloma program currently being run at Ambath. Put your hands together for Dr. Beatrice Melly. And the last one is a very senior colleague of mine. She used to be a very great friend of mine. Yes. But today we wanted to renew the friendship. Dr. Teresa Lotodo, for those of you who know her, she's a consultant pathologist. She also works with us at Moi Teaching and Referral Hospital. She's a senior lecturer at Moi University. She's very passionate about the training, mentorship of lab personnel, and she has a vision to work with the other healthcare workers to make hematology diagnostic services affordable and accessible to everyone. And I think that was the gist of the conversation this evening. Maybe to open this conversation. And unfortunately, I have to begin with Dr. Kalebi, with the last introduction of which I have done of Dr. Lotodo. How can we make diagnostic services affordable, accessible to everyone? And I want to ask the rest of you, please, if you have a question, you raise your hand. Thank you.
There's actually a time I gave a talk to Kenya Healthcare Federation, and it was a whole hour talk about the issue of affordability. I won't be able to answer in a few words. So I'll just summarize from a practical perspective. Number one, I'm a firm believer in social health insurance. That is the only way. All countries where care is affordable is because there's a social health insurance and a social health financing of healthcare. Think about it, wherever you go. So, whatever the problem we might be having with SHA, and I'm not here to pitch for anybody, I've been supporting social health insurance from NHIF days to now SHA. The day when you can walk in, I'll give you a practical example. When I was in doing my fellowship in South Africa, I keep thinking about this once in a while and I get emotional about it. When I was in my postgraduate doing fellowship in South Africa, I was in Baragwanath, but I was living in an area called Northcliffe because my family was there and I would commute to Baragwanath. Some of you guys know the area. My wife got pregnant with our fourth child. Actually, it was our fifth pregnancy. And literally, we were living hand to mouth. So broke, literally. And when we found out she was pregnant, despite using protection, she had been given by Dr. Marjan. That's why I named my son Marjan.
It's another story for another day. We had planned not to get pregnant, and then she got pregnant. Half of our money was going to us paying rent. The other money was basically, we didn't have, I had medical insurance because it was mandatory to have medical insurance as a fellow. But my family didn't have medical insurance. Then at, I think it was around 21 weeks or 22 weeks, she had premature rupture of membrane. And it was really gushing. So I rushed to Baragwanath. When I go to Baragwanath, I mean, it's like one of the busiest hospitals in the world, definitely in Africa. So there, as you are there, people are coming with gunshots. People are coming with knives sticking from their face. So nobody's really bothering with you. Then one of the nurses told me, this is a true story, one of the nurses told me, you have waited here for so long, what's going on? I explained to her about my wife, and I said she's really gushing. She said, where do you live? I said, I live in North Cliff. Then he said, there's another hospital. Actually, you're supposed to go to the nearest hospital. You're not supposed to go. So, you know what I got this, what is it called? Primary, there's something, the PCM or something like that. Huh? Here in Kenya, network. So you have to go to your PCN. So she says, why did you come all the way to Soweto? Because I said, because this is why I'm doing my fellowship. She says, no, there's another hospital there called, what's it called? St. Joseph. The name has just disappeared from my head now. But, Helen Joseph. Go to Helen Joseph. It is next to you. So I went back. I tell you, I walk into Helen Joseph. It is a public hospital, but it's better than Nairobi Hospital and Aga Khan. Kweli daktari? You know, he was there. Better. So I walk in with my wife, and the nurses there almost slapped me. You know those big Zulu women? Like, how did I stay so long? Because my wife didn't call me until I got home, and now it was more than, hey, now this lady is exposed to infection, blah, blah, blah. Then they asked me, does she have insurance? She don't have insurance. They almost slapped me again. Because they knew I'm a doctor. They almost slapped me again. Then they said, they wrote a note, and they admitted her. They started working on her, and they told me the next morning I should go to some director's office. The next morning I go to that director's office. They asked me, what is my income? I told them I don't have an income. I was on stipend. Then they said, they didn't believe me. So they said, you must be employed. I said, yes, I'm employed in Kenya, but I told them my salary is very little. They didn't believe me. They actually called. True story. They called Afia House. So I'm sitting out there. The guy came out. Ile huruma alikuwa nako. The pity he had on his face. He said, you mean I was being paid less than a watchman in South Africa. They said, you don't pay anything. So in South Africa, they have, you pay as per your income. And because they categorized me with my MO salary that time, I did not have to pay anything. Believe you, my wife stayed in hospital for many weeks, almost 6 weeks. Got the best care. My son today is doing very well. I did not pay a single, and everything was done. I keep thinking about it. You go to Canada, same thing. The day people can be able to do any test. I mean, you go to places in South Africa, somebody needs to be done all this bone marrows, blah, blah, blah. All the, Dr. Opakas knows. Everything will be done. So I think, if you ask me, the most important reason, the most important thing we can make care affordable, if you can have pooled funding for social health. People will never appreciate this. 2, in my view, other than that, is economies of scale. It's economies of scale. The more you do things, look at PET scan today. I mean, PET scan today is fairly affordable. Because you have more PET scans being done, more people are able to do it, flow cytometry. Now, number 3 is what we are talking about today. And I'm glad Daktari raised this topic. What I call about judicious and scientific approach to testing. so that we are not wasteful. I think those will be my general summary, but it's a whole lecture on its own.
Thank you, DKL. Any question from the audience? I know Jeptinga is very passionate about his training in South Africa.
Yeah. Good evening, members. Thank you, Caleb. Thank you, colleagues. This was an excellent presentation. It was really insightful, not only for me, but also for all of us. I just wanted to re-emphasize one thing, that over years, indeed, as a country, we have lagged behind. And one of the major reasons is because we are not being really innovative enough to bring the needful change. I remember some time back, I told Obakas that indeed, anything which is found in Cape Town should be in MTRH. And I'm happy that Obakas, you met it, and that's why we had it today. Nonetheless, my question to Kalebi, if you look at the lab, you'll agree with me that most of the tests which are done in the public hospital are less than 1% of the recommended tests. And this goes back to the issue of the training and maybe the structural, the chronogram of the diagnostics in our country. It's sad for me that today, that the Kalebi Lab had to be registered by the KLMT. Yet, we should actually have a national figure so that we have issues of structures, organization be straightened in our country. Secondly, the fact that how do you bring these tests? How will my colleagues know about this test? Because when I make a request here, I'll be able to access one or two. But we need a whole list so that our fellow Kenyans can know these are the tests available in our country and there's room to improve. I think that's one of our major limitations as we make. And finally, maybe concerning the issues of special cases, maybe you can open a link whereby the whole country can discuss, not necessarily individual cases because of the issues of the data protection, but we can have as a formal discussion and also learning processes, so that somebody in Nairobi or Eldoret or even Kisumu or even maybe Turkana can actually tell this is how to go about, so that by the time I'm referring, I know how to go about. I think those can help us to progress as a country. Thank you and have a good evening.
Thank you very much. You people will answer these questions. Yes, I can see pathologists here. I can see all kinds of people here. Dr. Obakas. Very briefly, just.
Thank you very much for an excellent presentation, Daktari. I must say that I had a privilege of visiting him, and I was shocked when I went to DKL Labs in Nairobi. If you have an opportunity, please go. Myself, personally, I've actually benefited patients who have seen. We've sent for molecular testing, BRCA1, BRCA2, and I've sent a couple of patients for NGS testing. Talking about the cost of oncology, sometimes you'll find, I just wanted to add about the cost of treatment. I visited a lab it was in Indiana, and another lab in San Francisco. And also, I know down south they do the same. When there's a tumor board discussion, because this is what we need to be doing, and we are not so sure about that, these are the tests which are actually discussed. They'll say that this is a sarcoma, they'll do an NGS test and say this is a sarcoma, it's not going to respond to cyclophosphamide. This disease is not going to respond to sorafenib. It will respond to imatinib. You can imagine the standard of treatment which you use to treat sarcomas. You give a blanket treatment, a patient doesn't respond to it, then you come back and say, okay, let's do a second line treatment. You've knocked off a patient's first-line SHA treatment. Then they go the second year, you've knocked out their second-line treatment. And then you can imagine the side effect of this, that this patient has to get. They lose their hair, they lose their health, they get very, very sick during treatment, especially for cancer. Why can't we? It makes a lot of sense to me, and I think we've started doing this year, and I've sent a number of patients actually. Why can't we be able to just do the way they will do it in more advanced countries? You run a genetic panel. I think you're doing 161 genes. One? Yes. So I usually request for the 161 because the difference is, I think, 5,000 shillings. And you will save, for the cost of maybe one cycle of chemo, you will save this patient a hell lot of trouble in terms of side effect. And secondly, the cost of care, if you look at the big picture, will come down. So mine is to say thank you so much for bringing this to us. And that was all. Thank you.
Thank you, Dr. Pakas. Now that you are not asking the panelists questions, let me pose a few questions on your behalf in the interest of time. Dr. Enoch Serem, you are a clinical pathologist. Many people don't understand what that is. I can see even your panelists are confused. Who is that? Yeah, and what exactly, in relation to the presentation that we have had this evening, in relation to what you do, how does that marry, the presentation and the practice of clinical pathology? Beatrice, you have worked with us for the last 10 years. But today, seated here, some of us are looking at our full blood count, and, we have been pushed even to doubt whether we should be requesting for it or not. The same thing on UECs, as earlier presented, very insightful kind of presentation. What do you consider is the clinical behavior of lab requests in relation to hematology? And how is that considered roughly costly to the patients that we manage in MTRH? And to Teresa, my sister, your passion in teaching cannot be discussed here. But tonight we keep on realizing how deficient we are with information in relation to translating, clinical knowledge to the lab. What do you think, in a nutshell, that can be done in terms of information, in terms of information, rather education, helping young doctors and even some of us who are very old in translating knowledge to clinical practice through the lab? I'll request that each one of you prepares to spend 1 minute in answering the questions that I've asked, and also respond to the assertions and the commendations that have been given by the various participants. So we begin with Dr. Serem.
Okay,
Why do you want to give to someone else?
Ladies first.
Okay, ladies first.
I was still taking my time with ChatGPT. Anyway, so thank you so much for that question, Dr. Mogeni. I think you asked a very good question. And first I have to say, complete blood count. We have very many names for it. Complete blood count, full hemogram. I had one today, Dr.
Full blood count.
No, I saw S something. What it is?
FBC.
FBC. So there are several names for it, but for me, a complete blood count is the stethoscope for hematology. It's an entry point that can give you a lot of information on what the problem would be. The challenge is what Dr. Kalebi said, that we don't take time to interact with it. It's in front of you, and I've seen maybe somebody just looks at the hemoglobin only and forgets to look at the white blood cell, to look at the platelets, and look at it as a complete, it's a complete blood count. And it's actually the mirror image. It gives us a sneak peek into what is happening in the bone marrow. So if you took time to interact with it, it gives you a very quick guidance on how you need to tailor your investigation. The next thing to that is the peripheral blood film, which is another very important test. And I'm actually impressed that there's an automated. I'm hoping it will come to us very soon somehow. Our turnaround time at MTRH is about 1 week because our team of hematopathology actually go out of their way. And sometimes if you call them, you can be able to get it even within 24 hours. Nonetheless, for diagnosis, for example, like what you mentioned, acute promyelocytic leukemia, it will not wait for 1 week. That let me say, peripheral blood film, if it was out before the patient left the emergency department, then that patient might have a chance in life. So that's why if you have a deranged full blood count, a peripheral blood film is paramount. It is a very good guide, and it even guides you on whether you need to proceed to now escalate to a bone marrow aspirate and a trephine biopsy and the likes. You had a question about the cost implication along the way. Most of the time, by the time the patient reaches us, actually they've been through, you will see, they come with their file and you'll see like 10 CBCs. You will be lucky. If you give a percentage, it will be 80% CBCs and about 30% of UECs and LFTs. And then now a few other additional tests. And even when they come, even at MTRH, because we are talking about quality control, it's like, no, I trust the CBC that the patient has, and you even send them for another one. Most of the time, if you take your time, you will be able to appreciate what the other teams have been able to do before you also do your own battery of investigations. So one is just due diligence in going through the investigations that the patient has already done. And now what we mentioned, being able to look at the bigger picture to the tail end. Because if you order your battery of investigations very quickly, or without looking at the tail end, then that patient will end up spending a lot of money and you have not been able to reach the diagnosis. Just 1 minute because I have a story. Yes, so I want to give a good example of a young man who is still with us. Actually, we diagnosed him with aplastic anemia 2 years ago. And this is after a bone marrow aspirate and a trephine biopsy. We did not do flow cytometry, and definitely we did not do the cytogenetics. So went all out. He comes from Transmara, and that time we still had a very good support with NHIF, and NHIF was able to pay for his antithymocyte globulin, which is 1.2 million Kenya shillings. So he got ATG, and you know ATG has some effect on leukemia as well. There's something called leukemia, like just somehow it can manage the leukemia to a certain level, and so the disease, I think, I have already preempted. So he improved somehow, but he continued, the cytopenias persisted to a moderate level. So 1 year down the line, he shows up again. Now the cytopenias are worsening, and it is not now just cytopenia. Actually, he has thrombocytopenia and anemia, but the white cells have started going up. And lo and behold, he has acute leukemia. Now, this time round, we ended up doing a flow with support. He was not able to pay the flow cytometry. So he has acute myeloid leukemia, which we've diagnosed how many years down the line? 2 years down the line. Now, assume we were able to do the beginning, do genetics, then maybe we would have picked the diagnosis of leukemia at that time. How much has that young man spent? More, definitely. Maybe we are at 2 million plus, or probably 2.5 million. And now we are stuck. We are still not able to give him the optimum treatment because of issues of SHA here and there. So for me, I think I'm hoping that at some point we can be able to have discussions on complete investigation for a client, and don't assume a client cannot be able to afford. Bring out the information, let them decide. If they are not able, then you scale it down or up accordingly. Thank you.
Thank you, Dr. Beatrice. Now that you said ladies first.
Thank you, Dr. Mogeni, for that question. And you are correct that I'm passionate about training and mentorship. And coming from a laboratory point of view, we know that we have 2 levels of lab practitioners. We have the lab scientists or technicians, and also we have the pathologists. And so there has to be continuous mentorship among these 2 groups. And how we have been able to do that is, one, through what we call multidisciplinary tumor boards, whereby when a patient is presented and the lab tests are presented, then you can be able to get expert input into the diagnosis or what further tests can be done. And so that's what even Dr. Kalebi said. We need to have that continuous communication between the clinicians, between the lab scientists, and also on the pathology side. We have been involved in some training of lab techs at Webuye County, and you realize that when people are trained in the college, sometimes when they go out there to practice, they find that there are some of those tests are lacking. And so you become you just concentrate on the few tests which are available, and then you lose knowledge and skills on the others. And so when we have that continuous mentorship, and we also have platforms like a WhatsApp platform where people can, put pictures there and ask questions. This is what we do routinely, and we are able to continue mentoring and say, no, this one looks like acute leukemia, we need 1, 2, 3. And then also, when you travel to outside countries, you find that we have the multi-head microscopes, which you can use to be able to, you have your students and all of you are able to look under the microscope. And so like when we are in our lab here at MTRH, and we have students from MTC, from the colleges around the camp, we need to continue showing them what we are seeing under the microscope. And so those are things that we need to continue mentoring the next generation. We also have something called Project ECHO. Project ECHO, like we have one which is lab-based, whereby we have people joining in, like once a month, we discuss a case, and then we are able to give input. So I think if you have that continuous, it should not be just a one-off training, continuous mentorship and, exchange and input from experts, then we'll be able to have, our patients diagnosed early and they get the right treatment. Thank you.
Thank you, Dr. Lotodo. Clap for her, please. Yes, now to the big man.
Thank you, Dr. Kalebi. Actually, Dr. Kalebi was my first employer post training. So to the first question, who is a clinical pathologist? So in short, a clinical pathologist is a pathologist who has specialized in the fields of hematology, clinical chemistry, molecular medicine, and microbiology and immunology. So we have specialized in these departments compared to the general pathologists. I think most of the trainees from University of Nairobi are general. They do both what we do plus histology. So I just don't do histology. I don't do the postmortems there. So we work in the lab. We diagnose diseases with lab techniques. Specifically in hematology, We review the abnormal CBCs, we report the PBFs, we report the BMAs, abnormal clotting profiles, and also we offer we bridge the gap between the clinician and the lab. So we also offer a consultancy service when we see something abnormal. What is the diagnosis? What is the approach to diagnosis if we need to? And in short, that is the work that we do in the clinical hematology laboratory. So we are quite few because pathology is not very sexy for doctors. So we are few, but ideally, most all sections of the lab should have a pathologist who is able to guide and to bridge the gap between the testing and the patient. So because we've done the patients.
Doctor, how can we make use of you?
So currently, you need to talk to us. Currently, we right now, mainly in hematology and microbiology. So most infectious disease specialists and hematologists, we have interacted with them. We still have a big need, especially in clinical chemistry, which is actually a very big specialty, a very hard specialty. And those who have gone to South Africa, they've seen how clinical chemists actually improve patient care. So if you, many of you have seen my reports in the PBFs, especially, and the thing is to communicate. You know, if you don't communicate, there's no way you're going to get use of my talent, and I'm not going to also help the patient because it's about the patient at the end of the day. So in short, that is what I do, and especially in the hematology department.
Thank you very much. Clap for Dr. Serem, please. And back to Dr. Kalebi. I know you have so much to speak, but we need to do some launch here.
Yes.
Yes.
So I'll just very brief.
First of all, in response to your comrades in South Africa.
Yes.
And Serem, you're also in South Africa?
I was in Aga Khan.
In Aga Khan. Okay, fine. Thank you.
So just to add to clinical pathology, very briefly. So clinical pathology is basically, think about them that they are doctors who are specialized in lab tests, and they can then interpret things from a medical perspective. The best way of making use of clinical pathologists is when you get a result that doesn't make sense to you, kubali tu, haujui, and call the lab and say, who is there who can interpret this to me? And if you call as a doctor, most likely it's the clinical pathologist who will end up discussing that case with you. And that's actually what gives them the joy, gives us the joy, even as general pathologists, to discuss cases. And every time you discuss, you discover a different dimension of things, which then goes into Dr. Cheptinga's question, how can other people learn from what we see? I mean, I have so many cases that we can discuss, and there's a learning point. In Nairobi now, and I've seen, I'm sure MTRH as well, but I've seen now even places like Meru, Kisii. For malignancies, they are almost all challenging cases and interesting cases are discussed at the MDT. And it becomes a very useful learning point, a teaching case. And I think more people taking cases to MDT, basically multidisciplinary meetings. I don't want to call them tumor boards. It's multidisciplinary meetings. So nowadays in Nairobi, for example, at Kenyatta particularly, they will even bring non-tumor cases for multidisciplinary. Because it's when this person talks, this person talks, and the penny drops. What I will encourage is you don't have to have a structured multidisciplinary meeting. If you have an interesting case, a case that doesn't make sense, I'll give you an example. Your friend, Dr. DK Kimani. DK Kimani the other day calls me, tells me
he has this and this case. I immediately added somebody else on a call, a radiologist. We literally had a multidisciplinary meeting within 10 minutes, 12 minutes, and we had a way forward. So, Dr. Cheptinga, I think the key thing is, how can we have more involvement? Now, in our lab, one of the things you'll see, and I know a few people have commented about this positively, others negatively, our histopathology report, for example, it has pictures. So you actually put pictures, histopathological pictures, that you can literally take to a colleague of yours abroad and say, can you interpret this? And they can look. We are able to give a link for you to be able to view images. For flow cytometry, we even share with you the flow cytometry charts. That allows for multidisciplinary discussions. One of the things I'm hoping to do in future is to create sort of like a database of case series. So that, let's say Dr. Bailey wants to look at cases of PNH, paroxysmal nocturnal hemoglobinuria. We have the full database there. It can be a learning point. And those are some of the things that becomes published later. Finally, how can doctors know about our tests and the tests that are available? This is one of the things we try to do. But as I said, we actually have our website. All the tests are there, including, one of the things we have tried to do is to give test descriptions. So you pick any test. I mean, this morning, just this morning, somebody actually asked me about several, I mean, there are many tests, but I'm even trying to remember which particular test. I think it was MDMT, which is for brain. And I remember I asked myself, why is the person asking me about this test? When I went to our website, we had not put the explanation. So we actually put explanations there. So Daktari, the easy thing to say is, and I'll just conclude by this, anytime you have a patient, you have made a clinical diagnosis. But the clinical diagnosis is not absolute. In other words, you're not entirely confident. You need to do tests. The simple thing is, the way you have been taught, what is the differential diagnosis? What are the tests that I can do? The minute you realize I have test 1, 2, and 3, go to our website, call us. Do you have this and this and this test available? We'll say yes, or we'll make sure it's available for you. And if people I mean, you made I'll finish off by a very profound statement you made. Somebody working in MTRH and somebody working in, what's that hospital? Is it still there? There was Singishu County. You know, it's chalk and cheese. See, there are chochote. But if you are in MTRH, the person who is in your Singishu will forget most of the things because they don't have the professors to keep nagging them and all that. But if we made it a habit that I have a patient, and I like what Professor Lule used to say. You see a patient, you know this patient cannot be able to do this test, but write it anyway in the notes. You know, patient has hemolysis. This could be some membranopathy, and we need to do clinical exome sequencing. Write it there. Let them not do it, but at least utakumbuka. The day you'll go to another place, it's not like you have forgotten it completely. Let's make use of our brains. Let's make use of the resources that are there. Give the patients the options. Let the patients say, I can't do it, but at least you have made them aware. Thank you very much.
Thank you. I think that marks the end of our discussion, and I'm very much grateful to the discussants. You can say that they have done justice to the topic that we had this evening. Supported by the Kenya Medical Association and co-supported by the Physician Association? Is it a North Rift chapter? Yes. We are very much grateful that that has happened. Kenya Medical Association is the association for all doctors. So if you are a doctor and you've not renewed your membership, please do so. And if you are a doctor and you have a friend or a colleague who has got some special issues, like mental issues, please liaise with us because the association has got a platform to assist. And if there are young doctors who are having serious issues, there is a young doctors network so that we are able to link them for purposes of mentorship and innovation. And Dr. Kalebi, you know, we as KMA, we are pushing young doctors to be mentored. So if you have a way of mentoring some of them to think about pathologists, clinical pathologists, you know, Dr. Lotodo, you know, the echo, the things that you've mentioned. Please, if you are a very young doctor, you, in quotes, pre-intern, which the terminology I don't like using because, you know, this is a creation of the current situation. Please, avail yourselves to your colleagues here. Very many that I'm seeing around who are willing to hold your hand for the sake of the profession. And for the people who are here and they are farm techs and you are running your laboratories in town, you've heard that we have a center for knowledge. I mean, we have an opportunity to share and collaborate either with institutions or with the seniors who know, you know, how to interpret these things. So make medicine flexible and let the patient be the focus. So I want to invite Dr. Chakait, our newly elected Kenya Medical Association Vice President. And I also ask Professor Kimaio. I heard they also mentioned the PNAP. What did you call it? You know, I was listening. Okay, fine. And I don't know who else to ask, but we just need to launch this lab here. And the team that is already there, just remain where you are. Where is Professor Kimaio? Yes, please. You know, I know you are a very visioned person. Yeah, and I do not have authority to order you now. Why do you put me in difficult situations? Yes, those who give chairs, why are you delaying, bana? Weka kitu huko mbele. Yeah. Yes. So, where is the person who introduced us? What was her name? Rosemary, where are you? You decided to go to kitchen. Yeah. So I hear, and I'm not sure, and this will be confirmed. Rosemary, you can come. That DKL is now in Eldoret. Okay, that's what I have heard. So why can't you guys clap for them? Yes. So I don't know how to launch a very serious thing like this. Yeah, but we stand guided on how to be part of this very big occasion. Thank you, Rose.
Okay, thank you, everyone. Now we are going to cut the cake, and after cutting the cake, we are going to cut the ribbon, and then we will serve our dinner. Karibuni.
So are we cutting the cake? Fine. Should my very big guests remain standing? Nasikia Teresa anasema kama ni keki lazima tusimame. Wacha ilete hapa hivi. Yeah, after the launch. After the cake. Yeah. Dr. Days Coril, just be preparing for a photo of thanks immediately after people have munched this cake. Kwani kuna wimbo ama?
Even a fool could see that you'll soon be leaving me. But each and every heart must take its
Prof. Kimaio, you are the tallest, so you'll have a chance to see the cake much faster than anyone else. And our Vice President, Kenya Medical Association, please prepare this food for the congregants. Thank you very much. Claps for this. Yes, so this evening, you guys, ladies and gentlemen, you'll have an opportunity to test the cake, courtesy of Dr. Kalebi Labs. And it's a very nice thing that he has arrived in this town in a very big way. We do hope that we will find it as a reason to make all Eldoret the second biggest home. And support the labs here and also support the facilities in Eldoret. And the more important, also support real education like the one we are having this evening. Yes. So I'm told. Thank you very much, Dr. Jakaiti. You've heard that Dr. Kalebi Labs. No, but you know, he has to report that at a higher national level that we are doing serious things. Thank you very much. Daisy, as people eat the cake, I think you needed to step forward so that we can prepare. You can prepare for a vote of thanks. Imagine I don't. Yes, gluten. Yeah. You will make. You I don't eat cake. Oh, really? Yes. But I'm okay. I don't. It must be having gluten. Where is it?
Right at the door.
I'll ask the rest of us to give us 1 minute. There's a ribbon to be cut. As the cake is being served, then Daisy will give a photo of thanks. I was not very well, but we can have the Kenya Medical Association Vice President.
Yes.
And
He's not dressed for the occasion.
and the problem here is, these are big names.
He's not dressed
They
up for the
can't.
occasion.
Have a good time tonight. Let's celebrate. It's all right. We're gonna have a good time tonight. Let's celebrate. It's all right, baby. We're gonna have a good time tonight. Let's celebrate. It's all right. We're gonna have a good time tonight.
Can all of you clap, please?
It's all right.
Thank you very much. Yeah. You need to sign the visitors book. Yes, that we were here. DKL, you have appetite for art.
It's a celebration. Celebrate good times, come on and celebrate tonight. 'Cause everything's gonna be alright. Let's celebrate. Celebrate good times, come on.
Which I see, you're not gonna say wait until tomorrow.
Nini watu wakufa bana. Kufa na maneno serious. Thanks a lot. Yeah, thanks.
Upstairs is where the small lab is. And,
you don't have to go.
Daisy.
and the other person
Answer kupeana a vote of thanks.
Okay.
Yes. Thanks. You always take a picture.
I took 3 years off.
I have the privilege of giving a vote of thanks and then under Kenya Medical Association.
I couldn't make it to the
So today we want to thank everybody who has made this occasion successful, starting with R&B Start Lab Eldoret. That is the director, Rosemary Lowe. Thank you very much for bringing these services closer to us. We would like to also thank Dr. Kalebi Labs, DKL, for venturing into Eldoret. We know Eldoret is a medical hub or a center for medical tourism now from the western part of Kenya and some of the countries around us. So we are happy that DKL has decided to venture into Eldoret. And we also want to thank the CEO, DKL, that's Dr. Ahmed Kalebi, for all the innovative tests that have been unveiled today. I think we've seen the video that was running, and some of the tests that we are seeing being done now are some of the tests we used to send patients to do in India or South Africa, and we are happy that we can now get them in Nairobi at a faster turnaround time. We'd also like to thank Kenya Medical Association, Eldoret Division, for hosting this event and collaborating with Kenya Association of Physicians in offering us the CPD points. And I would also like to thank our esteemed panelists. You've done a great job. Thank you very much for the session and for enlightening us on all things to do with pathology and hematology. And I would also like to thank the attendees. So without us, this event would not have happened. I thank everybody who has taken their time, whether it's the consultants, the medical officers, the laboratory technologists. We want to thank you very much for making time to grace this occasion. and being a good audience to our speaker and our panelists. And lastly, to thank also the service providers. I think the place is beautiful. This building has been there for quite some time, and this is the first event I'm witnessing within. So I also happen to be around this building a lot, and this is the first event. I didn't know this place could be transformed to a beautiful hall for events. So I wish to thank the service providers, the NICTEC company, the Romani Services, and Sagas Building, who have hosted us graciously in this building for the event. So thank you, everybody. And maybe the last question to Dr. Kalebi. We hope that your company can partner with our second largest referral hospital in the western part of Kenya to see whether we can get these special rates as well that KNH is getting. And to our oncologists, just to reiterate that never assume the patient cannot afford. By the time they come to you, they have hired vehicles and they have spent so much money. So they should be able to afford that flow cytometry that you'd like to do. So thank you, everybody. And thank you very much for this occasion. Thank you.
Once more before we close, I just want to call one lab technician to come and give maybe a vote of thanks. One lab tech. Thank you, thank you. Let us give him a hand.
Good evening. My name is William. I work with International Cancer Institute as the lab manager. And a point of correction, we no longer have lab technicians at the moment. Yes, we are only training lab technologists and lab scientists. And I want to thank you, Dr. Kalebi. I was one of your employees at Lancet. So you have really dignified the lab. For a very long time, lab was being viewed as a secondary aspect of patient management. But we really thank you because of the way you have dignified the lab so that it is being viewed as a core in patient management. So thank you all the lab techs who are here and the lab professionals who are here, the pathologists and everyone who has attended. May God bless you. Thank you.
Thank you so much. I just want to say thank you all of you once again. And now we are going to serve our dinner, and we are going to start from the first table, going to the second one, like that until the last one. Karibuni, self-service.
In what I say, my pledge is my bond. That's just my way. When you've made a promise to someone who's gone, well, that's when forever seems a little too long. I'm a man of my word, and I made you a vow. I swore that I'd love you, and I can't change that now. They tell me I'm free to find someone new. I just don't have the heart, 'cause I gave mine to you. But I said my love would last for all time, and no one would take your place. Well, if that promise was the last sound you heard, kept it. I'm a man of my word. I'm a man of my word, and it's cost me so dear, 'cause those words are a prison without you here. And I'll go to my grave with this torch held high, but just once I wish I told you a lie. When I said my love would last for all time, and no one would take your place. Well, if that promise was the last sound you heard, well, you know I kept it. I'm a man of my word. Yes, I'll always love you. Be the first time that you made love. I'd be the first man that your hands touched. But we've both done our share of living, taking chances we were given. I've never been big on looking back. I don't care if I'm your first love, but I'd love to be your last. If I could do it over, I'd have waited for this moment to give my heart to you unbroken. But if our mistakes brought us together, doesn't really matter whether we were saints or sinners in the past. I don't care if I'm your first love, I'd just love to be your last. All I know is what I see when I look at you, and all I see is what I'm feeling down inside. And all I'm feeling is this feeling that I finally got it right. When I wake up tomorrow, I'm gonna throw my arms around you, thank my lucky stars I found you. 'Cause I know your heart hides so much more than any man has touched before, and nothing matters more to me than that. I don't care if I'm your first love, but I'd love to be your last. Last night I had a crazy dream. Wish was granted just for me. It could be for anything. I didn't ask for money or a mansion in Malibu. I simply wished for one more day with you. One more day, one more time, one more sunset, maybe I'd be satisfied. But then again, I know what it would do. Leave me wishing still for one more day with you. One more day. First thing I do is pray for time to crawl. I'd unplug the telephone, keep the TV off. I'd hold you every second, say a million I love yous. That's what I do with one more day with you. One more day, one more time, one more sunset, maybe I'd be satisfied. But then again, I know what it would do. Leave me wishing still for one more day with you. One more day, one more time, one more sunset, maybe I'd be satisfied. But then again, I know what it would do. Leave me wishing still for one more day. Leave me wishing still for one more day. Leave me wishing still for one more day with you. One more day, one more day. If it would come true that one day your Prince Charming would come rescue you. You like romantic movies, you never will forget the way you felt when Romeo kissed Juliet. All this time that you've been waiting, you don't have to wait no more. I can love you like that, I would make you my world, move heaven and earth. If you were my girl, I will give you my heart, be all that you need, show you you're everything that's precious to me. If you give me a chance, I can love you like that. I'd never make a promise I don't intend to keep. So when I say forever, forever's what I mean. I'm no Casanova, but I swear this much is true. I'll be holding nothing back when it comes to you. You dream of love that's everlasting. Well, baby, open up your eyes. I can love you like that, I would make you my world, move heaven and earth. If you were my girl, I will give you my heart, be all that you need, show you you're everything that's precious to me. If you give me a chance, I can love you like that. You want tenderness, I I've got tenderness, and I see through to the heart of you. If you want a man who understands, you don't have to look very far. I can love you, I can love you like that. I would make you my world, move heaven and earth. If you were my girl, I will give you my heart, be all that you need, show you you're everything that's precious to me. I could love you like that. I would make you my world, move heaven and earth. If you were my girl, I will give you my heart.
It's undeniable that we should be together. It's unbelievable how I used to say that I'd fall never. The basics I need to know, if you don't know just how I feel, then let me show you now that I'm for real. If all things in time will reveal. One, you're like a dream come true. Two, just wanna be with you. Three, girl, it's plain to see that you're the only one for me. And four, repeat steps 1 through 3. Five, make you fall in love with me. If ever I believe my work is done, then I'll start back at 1. It's so incredible the way things work themselves out, and all emotional once you know what it's all about, and undesirable for us to be apart. I never would have made it very far, 'cause you know you hold the keys to my heart. 'Cause one, you're like a dream come true. Two, just wanna be with you. Three, girl, it's plain to see that you're the only one for me. And four, repeat steps 1 through 3. Five, make you fall in love with me. If ever I believe my work is done, then I'll start back at 1. Say farewell to the dark at night, I see the coming of the sun. I feel like a little child whose life has just begun. You came and breathed new life into this lonely heart of mine. You threw out the lifeline just in the nick of time. One, you're like a dream come true. Two, just wanna be with you. Three, girl, it's plain to see that you're the only one for me. And four, repeat steps 1 through 3. Five, make you fall in love with me. If ever I believe my work is done, then I'll start back at 1. You're like a dream come for the rest of my life. You don't have to think twice. I will love you still from the depths of my soul. It's beyond my control. I've waited so long to say this to you. If you're asking, do I love you this much? I do. in my world before you. I lived outside my emotions, didn't know where I was going till that day I found you. How you opened my life to a new paradise. In a world torn by change, still with all my heart, till my dying day, I do cherish you for the rest of my life. You don't have to think twice, I will love you still from the depths of my soul. It's beyond my control. I've waited so long to say this to you. If you're asking, do I love you this much? Yes, I do. If you're asking, do I love you this much? I do. Oh, I do.
But I don't wanna use you just to have somebody by my side. And I don't wanna hate you, I don't wanna take you, but I don't wanna be the one to cry. And I don't really matter to anyone anymore. But like a fool I keep losing my place, and I keep seeing you walk through that door. But there's a danger in loving somebody too much, and it's sad when you know it's your heart you can't trust. There's a reason why people don't stay where they are. Baby, sometimes love just ain't enough. Now I could never change you, I don't wanna blame you. Baby, you don't have to take the fall.
Yes, I may have hurt you, but I did not desert you. Maybe I just wanna have it all. It makes us sound like thunder. It makes me feel like rain. And like a fool who will never see the truth, I keep thinking something's gonna change. But there's a danger in loving somebody too much, and it's sad when you know it's your heart you can't trust. There's a reason why people don't stay where they are. Baby, sometimes love just ain't enough. And there's no way home when it's late at night and you're all alone. Are there things that you wanted to say? And do you feel me beside you in your bed? There beside you where I used to lay. And there's a danger in loving somebody too much, and it's sad when you know it's your heart they can't touch. There's a reason why people don't stay
stay who they are. Baby, sometimes love just ain't enough. Baby, sometimes love, it just ain't enough. Oh,
Throwing down the sickest rock. Turn it up, because Ray and DJ Protege are live on your radio.
Staring out into the night, trying to hide the pain. I'm going to the place where love and feeling good don't never cost a thing. And the pain you feel's a different kind of pain. Well, I'm going home, back to the place where I belong, and where your love has always been enough for me. I'm not running from, no, I think you got me all wrong. I don't regret this life chose for me. But these places and these faces are getting old, so I'm going home. I'm going home. The miles are getting longer, it seems, the closer I get to you. I've not always been the best man, a friend for you, but your love remains true. And I don't know why you always seem to give me another try. So I'm going home, back to the place where I belong, and where your love has always been enough for me. I'm not running from, no, I think you got me all wrong. I don't regret this life chose for me. But these places and these faces are getting old. Be careful what you wish for, 'cause you just might get it all. You just might get it all, and then some you don't want. I was blown away. Be careful what you wish for, 'cause you just seem to make sense. You're taking away you just might get everything, and I can't deal with that. I try to see the good in life, but good things in life are hard to find. Well, blow it away, blow it away. Can we make this something good? Well, I try to do it right this time around, and let's start over. I try to do it right this time around. It's not over, because a part of me is dead and in the ground. This love is killing me, but you're the only one. It's not over. Taking all I could take, and I cannot wait. We're wasting too much time being strong, holding on. Can't let it bring us down. My life with you means everything, so I won't give up that easily. I'll blow it away, blow it away. Can we make this something good? 'Cause it's all misunderstood. Well, I try to do it right this time around, and let's start over. I try to do it right this time around. It's not over, because a part of me is dead.
Time to get out of bed. It's the Saturday Breakfast with Ray and DJ Protege.
What you said when you left just left me cold and out of breath. I fell too far, was in way too deep. Guess I let you get the best of me. Well, I never saw it coming. I should have started running a long, long time ago. And I never thought I'd doubt you. I'm better off without you. More than you know. I'm slowly getting closure. I guess it's really over. I'm finally getting better. And now I'm picking up the pieces. I'm spending all of these years putting my heart back together. Just the day I thought I'd never get through, I got over you. You took a hammer to these walls, dragged the memories down the hall, packed your bags and walked away. There was nothing I could say. And when you slammed the front door shut, a lot of others opened up. So did my eyes, so I could see that you never were the best for me. Well, I never saw it coming. I should have started running a long, long time ago. And I never thought I'd doubt you. I'm better off without you. More than you know. I'm slowly getting closure. I guess it's really over. I'm finally getting better. And now I'm picking up the pieces. I'm spending all of these years putting my heart back together. Just the day I thought I'd never get through, I got over you. At the time you passed away, all the trouble that we gave, and all those days we spent out by the lake, has it all gone to waste? All the promises we made, one by one they vanished just the same. All the things I still remember, summers never look the same. Years go by and time just seems to fly, but the memories remain. In the middle of September, we still play out in the rain. Nothing to lose but everything to gain. Reflecting now on how things could have been, it was worth it in the end. Now it all seems so clear, there's nothing left to fear. So we made our way by finding what was real. Now the days are so long, that summer's moving on. Reach for something that's already gone, yeah. All the things I still remember, summers never look the same. Years go by and time just seems to fly, but the memories remain. In the middle of September, we still play out in the rain. Nothing to lose but everything to gain. Reflecting now on how things could have been, it was worth it in the
Taking you on the ride of your life. Crank it up, because DJ Protege is red hot right now.
things that we are not saying. Can we see beyond the scars and make it to the dawn? Change the color